Hi. So next up on our tour of mental disorders are the mood disorders, unipolar depression and bipolar disorder, or what used to be known as manic depression. As you read about in your book and in the last lesson, major depressive disorder is characterized by a combination of symptoms that include things like depressed mood, loss of interest or pleasure in most activities, weight gain or loss, disturbed sleeping patterns, and many of the other things listed here and in the document you saw during the last lesson. Depression is a very serious illness with great cost to society and a relatively high prevalence. At any given time, about 6 to 8% of the U.S. population is diagnosable with depression. Many of these people also experience great episodes of anxiety or anxiety disorders, as depression and anxiety are often co. So in the next series of videos, you're going to hear about unipolar depression, but also about bipolar disorders. These are disorders where periods of depression are alternated with mania or hypomanic states. Mania is a very agitated state characterized by sleeplessness, heightened creativity, extreme bouts of energy and emotionality, insomnia, feelings of grandiosity, and invulnerability. And although the bouts of creativity, energy, and excitement may sound great, most people don't experience these as very pleasurable states. So as you listen to these series of videos on bipolar disorders, notice that there are different categories of bipolar disorder that are based on the distribution of the particular phases. Bipolar disorders typically have at least 4 types of phases. There's a depressive phase, a manic phase, a hypomanic phase, and a mixed phase. And the various types of bipolar disorder are characterized by how often the patient is in each phase and their temporal relationships to each other. So in bipolar 1, or the sort of classical bipolar disorder, typically slight or severe depressions can be seen alternating with episodes of mania. They're characterized by distinct manias and depressions, and the period of mania lasts at least 1 week in order for this diagnosis to be fulfilled. In bipolar 2 illness, the episodes of mania are not so extreme and often absent entirely. So bipolar 2, the disorder is characterized by less distinct and shorter lasting manias, hypomanias, and often very serious depressive episodes. It's often difficult to diagnose because the mania is not so obvious and hypomanic phases can last for just a short period of time. Patients who suffer from bipolar disorder with rapid cycling go through quick changes of episodes. To be diagnosed with this disorder, you go through at least 4 episodes of mania, hypomania, or depression within a 12-month period. There are 3 types: rapid cycling, with at least 4 phases per year; ultra-rapid cycling, with a change of phase within weeks or days, more than 4 episodes per month; and ultra-DN cycling, which is a change of phase within 1 day or more, on more than 4 days a week. So these disorders can be quite disruptive, as you can imagine. During mixed bipolar episodes, the symptoms of mania and depression occur in rapid rotation relative to each other, or they may even exist at the same time. In these patients, the mania and depression are quite mixed. For instance, rapid thought and speech, which typically occurs in manic states, can occur at the same time as an anxious depressive mood. A mixed state is called multiform, a clinical picture that is very difficult to diagnose and treat because it has so many different aspects and shows itself in many different ways in each patient that presents. Finally, there's the most subtle form of bipolar mood disorder, often called cyclothymia or cyclothymic disorder. In these persons, the mood swings take place continually over a period of at least 2 years. The criteria for mania or depression may be kind of subtle and not quite fulfilled, but they appear independently of external influences. That is, there's no cause for their sadness or depression or excitement and mania. The transitions are typically very fluent, so that people can come into a clinic one day depressed, the next day manic. As you might imagine, it's quite difficult to diagnose cyclothymia. So what causes depression and mood disorders? Well, you may be getting tired of hearing me saying this, but the truth is we don't really know. It's clear that there are genetic influences, as there's a great concordance with identical twins both suffering from similar mood disorders or having a greater likelihood of suffering from mood disorders. But we also know that there are environmental factors, and we're learning particularly that sleep patterns are incredibly important. The genetic clues implicate neurotransmitter receptors and traffickers, but be very wary of the serotonin imbalance theory that you may have heard and that is widely popularized. These theories are, to put it mildly, very wrong. Serotonin and other neurotransmitters do have some effect on mood, but there's no evidence for any kind of chemical imbalance that causes depression. We're going to talk about this again in great detail next time when we talk about treatments of mental disorders, particularly pharmacology. But the idea of a chemical imbalance is simply wrong. Not only is there no evidence for such a theory, but it's clear that logically it doesn't make sense. The theory is based on the observation that some drugs, which are known to increase serotonin expression, may be useful as antidepressants. However, experimentally lowering serotonin does not produce depression, and raising it on its own does not relieve it either. It seems that these drugs which raise serotonin also have many other effects which might be the cause of their effectiveness in treating depression. And logically, it just doesn't make sense. Think about it. Alcohol relieves social anxiety. Does that mean that social anxiety is caused by an alcohol deficiency? Of course not. Simply because these drugs manipulate serotonin and they may have some effect on depression doesn't mean that serotonin itself is the primary cause of depression. One thing we do know is that there are a great many cognitive causes of depression. These include things like rumination or excessive thinking and obsessing about negative aspects or emotions. And these may come about because depressive disorders are so comorbid with anxiety. Disorders and the anxiety felt in general aspects of life may give rise to excessive rumination that leads to depression. It's also clear that cognitive constructs and biases, that is, the way we see the world, can affect our mood over long-term patterns and with great intensity. And learned behavior patterns themselves, where we avoid stressors but reduce positive feedback, can contribute to a chronic depressed mood. Now continue on in the sequence and watch these videos on obsessive compulsive and anxiety disorders, and I'll be back at the end with some concluding thoughts.